Everyone, please kindly take your seats. I'll give everybody a minute to come in and sit down. Take your seats. We have the second half of the day. Yes. Everyone, please take your seats. Okay, I'm going to get started. Should I give everyone another minute to get here? One. Okay. Great. I don't even have slides. Is the live stream on? Okay, great. All right, good afternoon, everybody. I hope you enjoyed your lunch and that you're all fed and ready for the second half of the day. If for those that don't know me, I'm Nicole Johnson. I'm a co-founder of the FOXG1 Research Foundation with Nasha, and I'm Josie's mom. So just like you, I am a FOXG1 parent, and I live the day in a life every day. This morning, my day started out with a phone call from Josie's pediatrician saying that her culture came back and she does in fact have a UTI. So, but she's okay. Because we've experienced this so many times before, we got ahead of it. So we're ready, armed with Cipro, and that's why my husband is at home. Hi, honey, thank you. So, let's just pray for the best. But we all understand FOXG1 life. And we had such a jam-packed beginning of the day to learn about the clinical findings of FOXG1. Thank you, Ellie and Kopika. The path to treatments, brilliantly presented by Sue and Guy, Terry. So we were loaded with a lot of science, and now we're going to get more into the lived experience, what we experience every day as FOXG1 parents. So it gives me such great, I'm so honored to bring to you some of the world's leading FOXG1 clinicians for our next session, which is the clinician session. Our first presenter is somebody who I met through the Epilepsy Awareness Day at Disneyland. I heard about this neurologist named Amanda Pong, and that she wrote a book called Seizure Freedom. Well, those are two words we love to hear together, seizure freedom. And Amanda is an investigator with some epilepsy clinical trials. And she is so passionate about parents truly understanding epilepsy medications. I mean, so many of our kids are on so many medications, but what do we really know about them? And do we know what's available? And do we know what's coming down the pipeline? So when I had the pleasure to meet Amanda, and we spoke for as long as she would possibly stay on the phone with me, I learned so much about the advancements in AEDs. So I was like, will you come to our conference? And she was so happy to. So Amanda is a pediatric neurologist in Bethesda, Maryland at Midland Atlantic Epilepsy. And I am so thrilled to welcome her to the stage to present to you all today. There she is.
Thank you so much for Nicole's kind introduction. I'm sort of diminutive, so I'll stand over here. It was really nice to hear all of the updates this morning, and I'm a little embarrassed to say that I think my talk is the only one that's not FG1 specific. But I think seizures are such a commonly found condition, and as Ellie and the others this morning spoke to, can be really such an overwhelming aspect of the disease. So, oh, do we have slides? Oh. Right. I've not used this, the green one. Oh, very good. Oh, yes. So I am a pediatric epileptologist, and I do a lot of rare conditions, and I treat a lot of epilepsy syndromes. And one of the most difficult things to treat is Lennox-Gastaut, which we'll talk about in a little bit. And I wanted to kind of aim high with this talk in the sense of talking about how we can achieve durable, sustained seizure control in this very difficult situation, but let it be kind of a learning tool to think about how we can treat other seizures, even if it's not squarely within the realm of LGS. It can be developmental epileptic encephalopathy or other refractory conditions. So I have no disclosures for research funding. I have eaten, I've drank, and I've stayed one night for a study. And so I want to just, 19 minutes is not very long, so I'm going to highlight some promising new agents and mechanisms, okay, which is how do drugs work, for difficult to treat epilepsies, including Lennox-Gastaut, developmental epileptic encephalopathies. I aim to try to expand our expectations from the drugs that are available and also talk about pipeline developments as well. So I like to start by presenting how we think about managing seizures. So when we have a patient with seizures, we try to gather as much information as we can, about the patient and their condition medically, and we make the first choice as best we can from what we have available of seizure meds. Now, unfortunately, it appears that even when we do this, about half of patients continue to have ongoing seizures, which is stated here as failure. That means you're continuing to have seizures. And at that point, we have to think about using the second med, which is either going to be in substitution or in combination. And historically, a third of patients have remained still having some level of active seizures. And at this point, we should really be directing our care towards tertiary care centers where we have people who are versed in the language of treating seizures with the most up-to-date medicines, surgeries, and so forth. And I think there's probably a fair number of people in the room for whom this is where we should be. Actually, I need a pointer. This is great. Okay, so after we get through the first two meds, we should be thinking more broadly about things such as surgery and trials and stimulatory techniques. Now, of course, these may not be equally appropriate for every case, and resection is typically not the situation for FOXG1, but certainly the others may be. So this is an image from one of our papers from Dr. Klein a couple of years ago, but is still fairly current, taking us through the timeline of seizure medications that have been available since 1850. And initially we had bromide, which was discovered by accident in pregnant women. And back then, trials were not really very, it wasn't really a thing yet. But since then, you can see phenobarbital came along early 20th century, and then there was sort of an uptick for a bit, first and second generation. And now we're well ensconced in the third generation of meds, so we're all the way up here. And you can see the line gets very steep because there has been a very quick development passage of new drugs for seizures, approximately one every 18 months. So we're kind of at the level of cancer drug development, so very quick. And the reason why we have such development, again, another image from one of the recent manuscripts from our group, is that there are lots of ways that we can go about treating seizures. In the old days, medications were oftentimes based on sodium channel mechanisms or GABAergic mechanisms. But nowadays, don't be too distressed about the complexity of this slide, but the idea is just to show that there is quite a diversity in the mechanisms present, both at, boy, now it doesn't work. Oh, here we go. Both at the inhibitory and at the excitatory junctions. You can see different ways where things work, as well as in the neuron that's sending the signal as well. So finding new mechanisms to treat seizures, and even new mechanisms to work at older targets, is fundamental to the development of new therapies. And before I go any further, I do want to say a word about Lennox-Gastaut. So Lennox-Gastaut is an epilepsy syndrome diagnosis. It is not one specific genetic, monogenetic or polygenetic condition. It can be due to any number of things, but it is childhood onset with developmental implications, a polymorphic EEG that has very particular findings, and many different seizure types as well. Unfortunately, the prognosis is not positive, with persistent seizures into adulthood in the vast majority of patients, behavioral problems, and sadly, a high mortality rate. Now, in Lennox-Gastaut, of course, there's been lots of trials. And this is borrowed from M. Scott Perry's slide, but has shown many different trials have occurred, starting in the 90s and through very recently with fenfluramine with NUP. And what I want to show about this is that there's an evolution in how the trials have been done, how we think about counting the seizures, how we record them, what we count as the seizure outcome of measure. This all kind of speaks to what was said earlier this morning about making sure we have measurements for the things that we really care about. But nonetheless, even though there's this heterogeneity, we can see that, really bad at this. We can see that there is, generally speaking, a fairly low percentage of seizure freedom that's occurring in these trials. And when it gets slightly higher, like here, for example, then we have to deal with some unpalatable toxicities of the medications. So I'm going to take a pause here and give a case interlude. And this is a family that, were it not for their trauma that they experienced with epilepsy experience, would love to be here themselves to tell you their story. And this is the story of the little girl on the left. She's a happy, bouncy 4-year-old explorer and gymnast who suddenly one day started having unusual spells. She started dragging her leg. She would be found in a pool of vomit. She would be amnestic to things that just happened. And pretty soon, it became evident that she was having seizures. As you can imagine, as she had more and more seizures, she became a little bit foggy, or what we call encephalopathic, which is evidenced in the middle. And ultimately, she spent her days like this, seizing 40 or more times a day with seizures that would incur injury. And she's seen here flanked by her 2 grandmothers who became, sadly, very versed in her care. Now, when I saw her, she had been seizing every day for 4 years. And when I see a patient like this, I use this grid, which I either borrowed or possibly stole from my old mentor, Dr. Blaise Bourgeois, who was a leader in the 2nd generation of meds. And when I saw her, I do what I typically do, which is I go through all the seizure types, and that's going to be the scribble on the left. But having an idea of how things evolved, what meds were used, what were the effects, what were the levels if we have them, any concurrent EEG, MRI, or other findings, any toxicities, any positive side effects, and so on. And so her map, as you can imagine, was very involved. It was many, many pages. It took about 3 hours on a Friday afternoon. And at the end of it, I more or less thought, well, she at least has what we call a developmental epileptic encephalopathy. And of course, you check the biomarkers, and her EEG cinched it for us. Classic textbook 2-hertz spike and wave. So you can see how this is kind of dominated by this kind of very rhythmic activity with spiking everywhere. And when she goes to sleep, she also shows patterns that are pretty much pathognomonic for Lennox-Gastaut as well. Oftentimes, there would be a seizure. So this patient squarely fell in the domain of considering things beyond the first 2 meds. She had probably been on about a dozen meds at that point. And we had the talk. So there were 2 available FDA-approved meds for Lennox-Gastaut at the time when I saw her that she had been naive to. And in addition, there was 1 trial for which she was eligible at the time. Now, in a situation like Lennox-Gastaut, you really want to make sure that all of your available options remain available. So if you have 3 options, you want to do them in a sequence that allows you to go through all 3 of them at some point if you need them, right? Hopefully you don't. So we rationed that she could try the clinical trial drug and would know within about 6 months whether or not that was helpful. And if it wasn't helpful, she could then move on to the other 2 that were already prescribable. And so that's what this family decided to do. And so there's a period called randomization, and this is not my talk on trials, but there's a period when you're either on the sugar pill or you're on the study drug. And within 2 weeks of that, parents told me that she had stopped having daytime seizures. Within the first month, they said she had stopped having her nighttime seizures, the tonic seizures where they sort of extend in sleep. And of course, we didn't really believe it, but her EEG was performed around that time. And you can see here that it shows an absence of that ongoing rhythmic 2-hertz spiking activity with the spikes inside. And also, these are just eye movements, but this actually looks really nice and continuous. And there's more pages, and you can see some occurrence of some of the normal rhythms popping up as well. So actually very encouraging. And she is now 2.5 years seizure-free. It has been, we've had many bumps in the road where she had a double infection. She had a UTI and double strep infection, pneumonias, whatnot. But she, throughout that, you know, every time there was a bump in the road, we would check her EEG, and it still looks like this, so I was too lazy to make more slides. And so at the same time, in person, this picture on the left is 1 month into her randomization. Her seizure dog is still very cute, but he had nothing more to do. And then she, in a couple months after that, joined her competitive gymnastics again. So, you know, some of us thought, well, this has got to be a fluke, you know, but I'm happy to report that we actually have pushing 10 Lennox-Gastaut kids and young adults seizure-free on a variety of new medications, some of them in trial as well. So, you know, perhaps we are moving the needle. Now, I do want to give you a little bit of direction in terms of where I would go if I saw somebody with Lennox-Gastaut or a difficult seizure situation. And there are 2 new landmark developments, the first being fenfluramine and the second cenobamate. They were trialed in different things. So fenfluramine was trialed in Dravet as well as Lennox-Gastaut. And cenobamate was trialed for drug-resistant epilepsy in adults, and further trials are ongoing. But to talk about fenfluramine first, this is a serotonergic med, and this is kind of a new hot topic in medication development. There are 15 or 17 serotonin receptors, and they each have subtypes A, B, C, D, so there's quite a few. But there's very specific targets for fenfluramine that I circled here. And in addition, there's other mechanisms with sigma-1 receptor, and possibly other ones that we don't understand, which make this medication both have multiple modes of action, as well as new modes of action that our previous meds didn't address. And what I want to point out about these medications too is that, you know, we don't just always want to hit the seizure count, we want to show some sort of difference in the other things that matter. And in the clinical trials for Dravet, looking backwards, Cross and others discovered that the mortality had gone down by 5-fold with the patients on Dravet as opposed to the ones who haven't been treated with Dravet in the past. So both the all-cause mortality and the sudden unexpected death, they all went down to rates that were 5 times lower with fenfluramine treatment. So this is an interesting idea. And I didn't make a slide of it, but one thought is that Carl Feingold's mouse model, the DBA1 mouse, in which one of the particular receptors is stimulated, the number 4, that perhaps that is the mechanism by which this change occurs. Another interesting idea is that, you know, we want our meds to be at least preserve, if not support, things like executive function, which means how does a patient regulate one's emotions, behaviors, cognition, working memory, and we want it to do so even if the seizure count, you know, is moving or not moving down, right? So the work of Bishop and others have found that these types of measures have actually improved in the Dravet patients treated with fenfluramine, and that it wasn't necessarily due to a decrease in seizures, okay? So these are interesting things to think about, because when we treat Lennox-Gastaut in these difficult conditions like FOXG1, we would ideally want a med that, you know, helps in multiple ways. Now moving on to cenobamate, which is the other thing I wanted to point out. It has a couple of unique mechanisms. I won't get too much into detail, happy to talk offline. But our older meds had specific ways of working at the sodium channel, which were a little bit non-specific and had different sort of areas where they were targeting, versus cenobamate, which works at something we call the persistent sodium current. And the nice thing about this is that when you have sodium channels, they're not all bad. You know, they're not one size fits all. There's some that you actually want to preserve, particularly in the neurons that help to dampen activity. Okay, so cenobamate actually leaves those well alone and sort of lets them do their job, and that's a good thing for fighting seizures. The second aspect about, oh, format changed. Second aspect about cenobamate's mechanism is that it works at the GABA-A. And I did say that a lot of the older medicines work at GABA-A, but actually there are different types of GABA-A receptors, and this one works in a way that helps, especially if the seizures are prolonged, because the target is still available for use, versus when we use benzodiazepines, they don't sort of work as well after something like 35 minutes. There were obviously clinical trials for cenobamate, and these were the pivotal ones, which showed a really amazing seizure freedom rate of 21%, and data since then in the real world have also reinforced a high seizure freedom rate. And typically in drug trials, the seizure freedom rate is expected to be somewhere around 3 to 5%, never over 7. And when this 21% came out, it was really kind of a blockbuster. So the convulsive seizures decreased remarkably by 93%. And in addition, these patients were able to stay controlled for up to 4 years, which is a very good period of follow-up. And on the back of these data, the FDA did something that they don't often do, which is they said that the phase 2 data was strong enough that they didn't require the next phase, the phase 3, to be performed, because it simply wouldn't be ethical at that point to have patients on a sugar pill and a drug that they already know works pretty well. So that's kind of like a gold stamp. We've talked a lot today about how many medications, the 173 combinations and so on, really scary stuff. Of course, we want everybody to be well controlled on less medication. And this study by Frito I wanted to point out because it does look at delayed folks with very, sometimes very difficult to treat conditions as well, DEE and Dravet. And these guys had been on previously 13 seizure meds and were on 3 meds or so when they were studied. And they had a pretty high rate of seizure reduction, 9% was seizure-free, but the point that's important is that they were actually able to reduce their overall drug burden while maintaining the seizure control. It's been shown that cenobamate is one of the drugs that can help us to potentially wean off other medications, and wouldn't it be nice, instead of 5, to be on 2? You know, that type of thing. So this is a very important aspect about cenobamate that I know it sounds to patients like, oh, we're starting you on another medication, but actually the goal is to get you on something that will allow other things to come off, okay? Now, also having to do with polypharmacy, when we have folks on different medications, we don't want to see too much interactions or like changes in effect because you're on other medications. And with cenobamate, it works independently of many of the other seizure medications that a patient might be on. So these bars, they kind of look like cookie cutters because from one med to the next, the responder rates of 50%, 75, 90, and 100 are relatively same across the board. And finally, oh, formatting issue again. So finally, mortality. We mentioned about fenfluramine. Similarly, in cenobamate, we also see a decrease in mortality having to do with overall mortality as well as sudden unexpected. And it goes down remarkably to the rates you see on the right. And some of these rates are better than or similar as general population. So I want to bring us to the future a little bit. This slide is constantly changing. I don't know how up to date this is. The case I showed you before, she was actually on soticlestat. And this is an agent that works at the cholesterol breakdown pathway in the brain. Cholesterol is very important in the brain because it helps to make our membranes. But they're having talks with FDA right now, so I'm not sure if the further studies will move on. But we do have another serotonergic superagonist called bexicaserin, which is open for Dravet and will be opening more relevantly for this crowd for developmental epileptic encephalopathy and Lennox-Gastaut. And this should be opening within the next couple of weeks. And then we have a anticipated BHV 7000 compound, which is a potassium channel activator. And that should be opening also broadly for DEE, so you don't necessarily have to have an LGS diagnosis. And I also recently heard that clemizole is starting a DEE type study as well. It was decades ago for antihistaminergic things and now is being looked at for serotonin as well. And ganaxolone is always on the list. It's a neurosteroid, something a little different, has been already studied for CDKL5 and refractory status. So these are potential things that you may take home as things to look into, because, you know, it's wonderful how the clinical trial development is going specifically for FOXG1, but of course we want to give folks options that they can pursue in the meantime that may be meaningful, you know, because FOXG1 doesn't wait for anybody. Anyway, thank you so much for your time, and I'm happy to take questions.
Questions after everybody's presentation?
Yeah. Okay.
Okay, thank you so much. Thank you so much, Amanda.